Today we will be talking about the pathologies of the hepatobiliary system. Our hepatobiliary system is composed of the liver, the largest organ in the body, and can be located in the right upper quadrant of the abdomen. It has functions such as metabolism of substances delivered via its portal circulation, synthesis of substances including those concerned with blood clotting, storage of vitamin B and other materials, and detoxification and excretion of foreign substances. We also have gallbladder, a digestive organ, and a pear-shaped sac located on the undersurface on the right lobe of the liver. Its function is to store and concentrate bile that has been produced in the liver. The biliary tree is also included in the hepatobiliary system. This is a system of ducts that acts to drain bile produced in the liver into the duodenum. And last is the pancreas, as it is closely related and shares a portion of the biliary ductal system. Pancreas is an elongated, flat organ that obliquely crosses the left side of the abdomen behind the stomach. It is a powerful digestive organ. Its functions are both exocrine and endocrine. Exocrine function is concerned with production of the three digestive enzymes: trypsin, that assists in the digestion of protein; amylase, that helps to break down large molecules of starch into smaller molecules of maltose, which eventually are broken down into glucose and stored in the liver; and lastly is the lipase, that assists in breaking down lipids into fatty acids and glycerol. While the endocrine portion of the pancreas consists of multiple clusters of specialized cells termed islands of Langerhans. The specialized cells are classified as alpha cells and beta cells. The function of beta cells is to produce insulin, and alpha cells produce glucagon, both of which are discharged directly into the blood from the pancreas. Insulin and glucagon regulate carbohydrate metabolism. First pathologic condition for hepatobiliary system is the alcohol-induced liver disease. Alcohol is a known toxin which, when metabolized by the liver, causes cellular damage. Alcohol cannot be stored in the human body, and therefore, the liver must convert it through oxidation to alcohol dehydrogenase, acetaldehyde, and acetate, all of which reduce cellular function. Chronic alcohol abuse often leads to fatty liver, followed by hepatitis, cirrhosis, hepatocellular carcinoma, or all of these diseases. Fatty liver is the most frequent early response to alcohol abuse. Fatty infiltration may be demonstrated by using CT or sonography, but CT is currently the examination of choice. CT demonstrates the fatty deposits as hypotense areas throughout the liver. Next up is the fatty liver disease. These are fatty infiltrates within the liver. This pathology develops as lipids accumulate within the hepatocytes, forming free radicals. At some point, the liver cannot rid itself of these excessive triglycerides. This results in an excess of fatty acids within the liver, which leads to fatty infiltration of the liver termed steatosis and fatty liver disease. In the early stages, non-alcoholic fatty liver disease is often asymptomatic, and diagnosis requires biopsy of liver tissue. The disease progress is slow, but it may advance to cirrhosis if left untreated. Management includes implementation of weight loss programs and exercise programs as treatment for insulin resistance and associated metabolic disturbances. Aside from obtaining it due to alcohol abuse, there are also people who have an increased risk of developing non-alcoholic fatty liver disease, or what we also call as NAFLD. These are the obese individuals with type 2 diabetes mellitus, metabolic syndrome, and hyperlipidemia. The image that you can see is a comparison of a normal liver and fatty liver from CT scan. A normal liver has slightly greater attenuation than the spleen and blood. The intrahepatic vessels are visible as hypoattenuated structures. Compared to fatty liver in an unenhanced CT scan, the attenuation of the liver is at least 10 Hounsfield unit, less than that of the spleen, or the attenuation of the fatty liver is less than 40 Hounsfield unit. In severe cases, intrahepatic vessels may appear hyperattenuated relative to fat-containing liver tissue. Next is an ultrasound image comparing a normal to fatty liver. In a normal liver, its echogenicity is equal or minimally exceeds that of the renal cortex or spleen. Intrahepatic vessels are sharply demarcated and the posterior aspects of the liver are well depicted. While in fatty liver, the liver's echogenicity exceeds that of renal cortex and spleen. There's also a poor delineation of the intrahepatic architecture and loss of definition of diaphragm. Another inflammatory disease is cirrhosis. It is a chronic liver condition in which the liver parenchyma and architecture are destroyed, fibrous tissue is laid down, and regenerative nodules are formed. It affects the entire liver and is considered an end-stage condition resulting from liver damage caused by chronic alcohol abuse, drugs, autoimmune disorders, metabolic and genetic disease, chronic hepatitis, cardiac problems, and chronic biliary tract obstruction. The functional impairment caused by cirrhosis or impaired liver function caused by hepatocyte damage, generally resulting in jaundice and portal hypertension. Next is ascites. It is the accumulation of fluid within the peritoneal cavity and is also seen as a result of portal hypertension and the leakage of excessive fluids from the portal capillaries. It may also result from chronic hepatitis, congestive heart failure, renal failure, and certain cancers. These are the two diagnostic images that shows ascites. An abdominal sonography is commonly used in the detection or confirmation of ascites. In the CT scan, it shows a shrunken liver with significant ascites around it within the abdomen. Diagnostic and therapeutic parasynthesis may be conducted with sonographic guidance to locate a site that will allow fluid to be removed and to avoid damage to the floating bowel loops. There are two recommended areas of abdominal wall entry for parasynthesis. One is the 2 cm below the umbilicus in the midline through the linea alba, or 5 cm superior and medial to the anterior superior iliac spine on the either sides.